how does the laser works. And I got aware there were some questions. So, and I hope, okay, maybe with, okay. So my name is Roland Herzog. I'm Business Development Manager, Energy Device, based in Tuttlingen. It's in the south of Germany, and I'm traveling and doing a job for high frequency and medical laser systems since 27 years in Martin Company. India is a main country, and I like always to come here. The Martin Company is a very old company, old-based German company, and we are a family company founded in 1896, and we have more than 2,100 employees worldwide, more than 16,000 products and activities in more than 140 countries in this world. And of course, we have here our India presence, started operations with complete office in 2016. And we have there our excellent sales and service team. And it's called KLS Martin India. We have it in Chennai and we have it in New Delhi. So always welcome to contact them if you have any questions about our products. In Germany, and we invite you cordially, we have our main logistics center, our administrative building, and our training center. And therefore, we give technical trainings and medical trainings. Everything is available there. And Tuttlingen, in the meantime, as you can see, is more colder weather. We starting into the winter period, and therefore you see the sky there. It's always a little bit more cold. We have now 12 to 14 degrees. We're starting into the winter time. But fresh air, and we are living in the mountains, and it's a very nice environment. Our development and production is completely in Germany, and our international sales and distribution in more than 140 countries. So this our small town, maybe you will be surprised. We have only 35,000 inhabitants. This is nothing. For India, of course, you have a complete other dimension when you are together with a lot of people. We are 35,000 inhabitants, but all these people are involved in the medical field. And I am sure you know KLS Martin Group, you know Storz Company, maybe you know also Escolab Company. We are all neighbors. All these medical companies are on one place. And you are welcome to see this place once a day. More information. This Tuttlingen is located in the near of the Lake of Constance. That means this is the part to reach France in 1 hour, to reach Switzerland in 1 hour, to reach Austria in 1.5 hours. So let's talk about laser. What is the laser? Laser means light amplification by stimulated emission of radiation. It's an art word. And we have a generating of a laser radiation. How does this go? That means the radiation is highly collimated and the rays of the beam run almost in parallel. That means, as a result, the laser beam's diameter hardly increases, and even over long distances. If you look to a bulb or conventional light source, this is not collimated light, okay? But if you have a laser light, then you have a very collimated light with a high density, with a high energy point. You have as well a monochromacy. That means the laser radiation is monochromatic, only one wavelength, one frequency, that means an energy. The visual range of our eyes is between 380 nanometers and 780 nanometers. So that means we can only see the rainbow colors. That is what we can see, but you see on this range there is a lot more of wavelengths we cannot see. Maybe other animals or something can feel more than we can, but we have below 380 nanometers the short waves. This means the ultraviolet waves. And above the 780 nanometers, there are the infrared area. And this belongs to a neodymium YAG laser with the wavelengths of 1318 nanometers. Or even a CO2 laser, which has, for example, 10,600 nanometer. So how does a laser work? The basic structure of the laser is that we have to stimulate with an energy source a special medium. This medium can be solid, liquid, or gaseous, and that means if we stimulate, for example, with a high voltage, with a flash lamp, with a diode module, if we stimulate the atoms in this crystal, in this case we have an aluminium yttrium garnet, then we stimulating the atoms. So we have a high quality reflector and an output coupler. This is a partial permeable reflector. And all the atoms which are emitting photons, they bringing very parallel the photons through this partial permeable output coupler. And then we get the laser beam. So we have an invisible laser radiation. This is 1380 nanometers. We cannot see. So we need additionally a pilot laser. This is the red color you have seen in this operation when Dr. Darlong worked on it. And through this red beam, the invisible working laser beam will go through. And then we need only fiber, reusable fiber when we have a handpiece. Or we have also for VATS high temperature bare fibers where we can put onto this laser. So this is the beam guidance system. With the high temperature fibers, we don't need any handpiece. And with the other fibers where we can connect a handpiece, that means we do the application instrument on it, we work in the way Dr. Darlong showed today. This is additionally what I explained. In our system, we have a diode pumped ND YAG laser. Pardon? I have to wait? Yes, sir. Okay.
Mr. Roland, can you hear us from the OR?
Yes.
Yeah,
Yes.
sorry to interrupt. We would just wanted to show the last few, if you can have the display there.
Yes, yes.
After completely closure of the defect. Yeah.
Yes, yes.
So you can see I basically underrun that edges and we are not seeing any air leak now. You can see that. There is no air leak. That's the suture I've used, 30 PDS. I've underrun it from here to here You can see the amount of lung tissue that I preserved basically. There is no distortion much. Unlike if it was a stabler, it would have gone in basically maybe multiple fires. You can see the lung is expanded well. We don't see any air leak.
Yeah.
So, okay, Mr. Rohini,
Okay, I think that brings the end of the first case, and yeah, back to you, Mr. Roland. Yeah, we are signing off from the OT till we
getting the second case ready.
Second case ready. Yeah.
So, tube down. I see down.
Great. Thank you for showing us these pictures. So you see the diode pumped and the YAG laser means we have diode modules, they pumping onto this yttrium aluminium garnet. And then we will have some of the excited atoms or modules emit the photons, and these photons are going parallel through this partial permeable lens. And then we collimating with an additionally lens, which is the handpiece of Dr. Darlong. We collimating this beam. And that gives the high energy to cut and coagulate at the same time. The LIMAX laser is a success story. We have a lot of installations in the European core countries and, of course, worldwide installations, and doing more and more in this field. It's a flagship technology for our company, and we are really happy that we can have a door opener with this product. As a sailor, I like to show this picture. So, additional information. KLS Martin already started the manufacturing of lasers in 2000, and we are now 24 years of experience with this laser. The older laser was called MY40. And we improved a lot on this laser technique by ourselves with our engineers. And we found out that the wavelengths of 1380 nanometers is exactly the wavelengths where the beam is absorbing in the lung. And that's why we have a sealing effect into the lung tissue. So numerous of operations on the lungs are now performed using this modern 1318 nanometer diode pumped and the YAG laser. The laser device was specially developed for lung surgery and has special properties that make it possible to cut and coagulate the lung tissue at the same time. So we saw in the operation how does it work. So it will be possible not only to remove one nodule, you can also do many of them remove. This is a very important point, because if you use the stapler, then you have to cut out, let's say, a lot of healthy tissue. And normally you need 2 or 3 staplers for a one metastasis, and therefore with this laser you can go very precise into the removing of these nodules. So we thought, what is the alternative? Because I'm also specialist for high frequency, and the high frequency is not able to stop the bleeding. And I heard from the audience or from somebody that they think argon beam could be also a possibility, but I can tell you, argon beam is a very, very superficial coagulation. And therefore, you will never have this cutting effect. Argon can only make the coagulation superficially. And this laser has so much energy that you could see that it was melting during cut and was doing a cutting and coagulation at the same time. So I can tell you honestly, with high frequency, you have on the one hand always problems for stopping the bleeding because you cannot close the alveolus in that way. You can do this with the laser. And that's why, that was the reason why we invented the laser system. And the argon beam cannot stop the bleeding if it's come out with more power. And then you can only stop the superficial bleeding of the lung. Also, if this is once necessary, there is a possibility to repeat those cases. And even if it's on both sides, you can turn the patient, maybe not in the same operation, but I saw also that they made those operations in a one day, if they have to go on both sides. Only to make it a little bit simple, you see with the stapler you have a bigger loss of the healthy lung tissue, and with the laser you can go around with this safety margin, and then you can remove the metastasis very nicely. If you have multiple metastases, as you can see, then you can do this, remove it in that way. We heard a little bit, we have to have the anterolateral thoracotomy. That means the incision is between the 4th and the 6th rib, and then we put the spreader, and we can go and will reach the lung then. This is the common access for open surgery laser resection. So the median sternotomy cannot be done or will not be done with this operation style. So what is preoperative? We have the deflation of the lung on which the surgery is performed. Then after the thoracotomy, we have the liberation of the lung. Adhesiolisis, we have seen, we made that with high frequency. And then we have the palpation of the lung and the verification, elevation of the metastatic tissue by forceps or sutures, laser resection of the metastasis, safety margin we keep with 5 millimeters. And then after that, if necessary, we have a suturing zone maybe, or a bronchus was open and then we had to suture that. After that, we can do a rinsing of the lung while inflating and can check the air tightness. I got aware that there were some questions how to work with this handpiece. This is the handpiece, and let's say 2 to 3 centimeter distance is the focus. It's not only one point, it's a little bit a longer line, as you can see here. Maybe I can show this. So that means if you have 2 to 3 centimeter, you are more or less always in focus. It's always good to go in a right angle, if possible, and then you have the best quality of cutting and coagulation. Then the working speed is also an important thing. Dr. Darlong showed it very nicely, not being too fast, giving a little bit time, and then you melting the tissue very nicely, and you seal better. This is a little bit an experience by each doctor, and he need to work with. The power is between 60 and 80 watts, and step by step, some doctors like it more with the 60, others, they go a little bit with a higher power. This is a matter every doctor decides by himself. It works in any case. So VATS can be also performed. Of course, we have special fibers for VATS, and in the meantime, high temperature fibers. So there is also an advantage that you can go in contact with the fibers or working in non-contact. With a handpiece, you can only work in non-contact, and with a fiber, you can also go in the contact. So here, preoperative is the same, deflation of the lung. Intraoperative, we have multiple small incisions to the thorax, and then we do the laser resection with the fiber. The safety margin of the fiber is the same, like with the handpiece, and then we do the suturing zones when necessary as well. Very easy access to work with bare fibers. They call it bare fibers. Of course, we need laser goggles because in any case when we do the open surgery, because the reflection of a laser can maybe reflect to the eyes. This is the most critical point. We should never get a laser beam into our eyes, because that will coagulate the retina or something, because it's absorbing in the water, and our eye is also with liquid, so therefore it will absorb. Of course, there is always a distance, but even over a distance, those lasers have a high energy. So only activate the laser inside the wound field. It's not dangerous. It's only, you have to know this. So here you can see directly how powerful the laser is working. This is with the handpiece from a distance in the same way we saw this today. Then inside the other field is also bronchoscopy. So you can go with the fibers through an instrument here, and then you can apply the fiber into the field. Here you can see that better. This is the fiber, and it gives the energy into this field. So we use the Limex laser in the thoracic surgery, open surgery, and VATS, and we can use this very nicely in the endobronchial surgery. So we can remove multiple metastases. We can do reoperation. That's possible. We can put this. It's applicable on patients which have been inoperable, and even deep-seated and centrally located metastases, and smallest and biggest sizes we can remove. What is additionally with this laser? We have a smoke absorption system on that laser. That means if you press the foot switch, the foot pedal, you absorb the smoke as well. Then everything is under control. This is the only connector for the fibers. And here we have the rotary knob to make the programs very easily. Simple and forward operation display without any problems. You need only 2 or 3 programs and everything is ready. Then we have here laser and pilot beam and the smoke evacuation system and the air support for cooling. Clear display structure with doing the settings for open surgery, for VATS, or for bronchos. This is the foot pedal. This is a very special one. You see the light blue and the gray one. The gray one is the activation, and with the light blue you switch from 80 to 60. So we have a swap mode inside, so the doctor can always swap by himself whatever he wants to have. So between 60 and 80 is a good switching activation. This was the handpiece. We can also autoclave the part, the light blue part. And these are the bare fibers, which are maybe very interesting for you to do the VATS. And what I highly recommend are thermostable fibers with 600 micron or 800 micron. There is a preparation kit, and so we can refresh the fibers even during the operation and, of course, before. With such an instrument, we can guide the fibers, and we can also bend the fibers intraoperatively. So that is a very easy handling to access. We have all technical data, clinical papers are available. Also here you can see Dr. Darlong wrote one, and we made some workshops in former times, India, Philippines, Peru. Also in Estonia, there was more VATS. Indonesia, they made, this is maybe interesting for you, the advertisement, the hospitals made the advertisement via the newspapers, and then the patients come from themselves. So please check with us. We are open-minded, and of course we are welcoming you as well in Germany. And this laser is really a good solution for the lung surgery. As you could see today, it was an excellent operation. My question is, first Limax 120 in your hospital, please go in contact. Thank you very much, and we will support you very nicely. Our sales team from India is always available for you. Thank you.
Thank you very much, Roland, for a nice presentation on the laser system. If you have any question, the industry people are here, we can interact with them. So just to save our time, we'll go to the next talk, a very pertinent one, especially about what happens to the imaging, post Nd:YAG laser. There's a lot of confusion. The reporting, you get to see some nodules left behind, some consolidation. There's a lot of confusion in the follow-up period. So I think we'd like to request Dr. Prerna, who helps us a lot in the radiology part. She'll be basically going to the focus point about how to interpret the CT findings post Nd:YAG laser. And so in the meantime, I'll be going back to the OT, and we'll having the next case ready. We try to keep the time as fixed as possible so we can have maximum time for hands-on laser. And thank you all very much for coming here. Definitely a pleasure. And Dr. Prerna, she'll be talking on CT chest imaging post Nd:YAG laser pulmonary metastasectomy.
Yes. So good morning, everyone. So I'll be talking on laser metastasectomy, imaging prerequisites, and the follow-up. So this slide is pretty much redundant in this crowd, I suppose, but still let's just go through it. Oncological criteria for pulmonary metastasis are that the primary malignancy is controlled or controllable, extrapulmonary metastasis is absent, the lung foci must be resectable without compromising the lung function and the physical condition of the patient. So now this is a very busy slide and it's a very complicated algorithm, but I have just put this to emphasize on the fact that The biology is the king and radiology is the backbone of doing a pulmonary metastasectomy. Biology decides whether biology and the radiology, as in the number of lesions, the location of the lesion, decides what approach should be used for the metastasectomy and whether the metastasectomy can be done or not. Now let's look at few imaging prerequisites. What kind of a test CT do we require for doing in a patient who has got metastasis? So most of us, I think at all centers, we are using a multi-slice volumetric acquisition with millimetric and submillimetric reconstructions, and doing a helical CT is pretty much redundant. However, if a helical CT is done, a slice thickness of approximately 3 to 5 millimeters should be enough. And generally, we need a slice thickness of approximately 2 to 4 millimeters when you are acquiring a multi-slice CT. How should the images be reviewed? The images should be reviewed on a PACS monitor. So you need to go back to the radiology, or if you have a PACS monitor, you need to scroll the images and look for additional metastasis. It's very well known that if you scroll the images, you will come across more metastasis than just looking at the static images. Are all nodules detected significant? So that's a very, very confusing question. With the improvement in the CT scanners, we are detecting a lot many nodules as compared, which are likely to be clinically insignificant. The most common problem that we face routinely is the subpleural nodules and the subfissural nodules, which may add to the confusion. And similarly, granulomas are very, often difficult to, you cannot differentiate between the granulomas and metastases at often. So the lesions which are more than 8 millimeters usually do not pose a problem. The problem are the lesions which are less than 8 millimeters, and more so the lesions which are less than 5 millimeters. The decision whether these lesions should be followed up, or they should be treated, or they should be biopsied is usually intuitive, and it is based on the biology of the tumor, and the decision is usually made in a multidisciplinary team meeting. Now let's look at a few images. So this is a subpleural nodule, but it is slightly hyperdense, so it was reported as a granuloma. Again, you see some nodular lesion with some fibrotic tags adjacent. So that's mostly fibronodular lesions. You have flat dome nodules. These are all subfissural nodules, a calcified granuloma. So these are all non-malignant nodules. Then how recently should a CT scan be done before doing a metastasectomy? It is reasonable to accept a good quality scan which has been performed 4 weeks ahead of planned resection, which is a reasonable compromise between having an up-to-date information and avoiding unnecessary expenses for the patient. Should a PET CT be done? The PET CT is not required to, to detect additional metastasis while doing a pulmonary metastasectomy. It is usually done to rule out extrathoracic metastasis. It's primarily for extrathoracic metastasis and not to detect additional lesions within the lung. For that, we just need a CT scan. And what interval follow-up is required after doing a pulmonary metastasectomy? So we need to have a reasonable purchase between the post-treatment changes being resolved and the new lesions have not appeared. So we need that period. But that usually does not happen. We'll always have a mixed picture. Some metastases, there'll be new metastases, and there'll be the old ones which have got some sequelae going on there. So what we follow generally is, if a lung palpation was done at the time of doing a metastasectomy, then it is reasonable to do a CT scan every 6 months for 2 years and yearly for the next 5 years. And if the metastasectomy was done solely based on the CT findings, then we need to have a shortened interval of follow-up. So this you guys are really, really aware of, so I don't need to, it's just basically a photothermal ablation, and it spares the parenchyma, it prevents the, a lot of lung fibrosis, and a lot of more lung lesions can be ablated with the laser metastasectomy. So now, why do we need to know the post-laser changes? Because the post-laser changes, very often, they will look like persistence of the lesion, or they will look like, these changes are very, they are very roundish, they have a very roundish configuration. So you may think that these are metastases. So that's why we need to compare the most important thing is comparing the pre-treatment images with the post-treatment images and then serially following them up, so you know that the lesion has eventually resolved. So the changes may look like consolidation, they may look like consolidation with cavitation, and you may see some pleural reaction or pleural thickening. So now let's look at few of our cases. So this is a case of a gastroesophageal junction tumor with left lung metastasis. So this was the nodule which was ablated. So a CT done within 2 months of the ablation, we see this roundish area of consolidation. This has got some rounded contour. You may think that the lesion has increased, but this is actually the post-treatment changes that we are seeing. What we are seeing here is some amount of pleural reaction. The size of the nodule that you are seeing at the base is larger than the lesion that you saw earlier. So it is completely covered by the ablation. This is the ablation zone that you are seeing. Now this is another case, colorectal metastasis. You see that there is an area of consolidation with some internal liquefaction or fluid attenuation area with some cavitation, and it is completely covering the area of consolidation. So this is again a post-metastasectomy change. So this is another case, a right lung nodule. Post the treatment scan shows a wedge-shaped area of consolidation, which is pleural based, associated with some pleural thickening and reaction, internal cavitation, and the area is larger than the nodule. So this is another nodule that we see in the left lower lobe. This nodular appearance was persistent for a long time. So we did a PET CT. So in this scenario, the PET CT helped us, and there was no uptick at that particular site on this PET CT. So this is another case where we see that there's a nodule. The area of ablation is more than the size of the nodule, and you are seeing some fibrotic, these linear tract-like structures reaching up to the pleura. So there are a few late changes that you will come across. That would be a thin wall cyst. You can see a cavity. You may see some fibrotic band, or at times you may see, of course, the new metastasis may have come up in your late scans. So here we see that there is a nodule. This is a case of CA colon. You have a nodule in the left lower lobe, which was after 3 months replaced by a thin walled cavity, which is completely covering the site of metastasectomy. You have these linear bands which are reaching up to the pleura, and later it was replaced by a linear fibrotic band. The cavity resolved. Similarly here we see these two nodules. Post-treatment shows a wedge-shaped area of consolidation. It became a thin walled cavity later, and fibrotic bands after that. So this was the same patient, underwent metastasectomy for this nodule. You see these bands here. However, in a later scan, we could see a new nodule which has popped up in the left lower lobe. So I just want to show you pictures of staple metastasectomy. So this was a case of Ewing sarcoma. What we see is a pleural-based defined nodule. Underwent metastasectomy. You see a linear hyperdense structure at the site of metastasectomy. That's the staple line. So thus to conclude, CT is extremely essential for diagnosis, treatment planning, and follow-up in patients with metastasectomy. The sequelae of ND-YAG laser metastasectomy may look like disease. So what we need to do is we need to review the pre and the post-procedural images, nodule by nodule, slice by slice, so that we are sure that these areas were completely covered by consolidation, atelectatic bands, or cystic areas, and there are no new nodules. Similarly, we might often need to follow these images up. I mean, you need to keep following these patients up so that these changes resolve when you know that these are actually post-treatment changes. And then you need to, if you're still in doubt, you may do a PET CT or you may do an HPE for these lesions. So this slide tells us the confusion that we radiologists usually face, whether this nodule is an indeterminate nodule or a non-specific nodule. And the decision is usually, again, very intuitive, and it is based on an MDT. Thank you. If you have any questions, you can ask me right away. Thank you.